This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with me tonight a very close relative, my brother, Dr. Don Robinson. Thank you for being with us, Don.
Well, it's great to be here, Joe Sam.
So we could talk about a lot of things. We certainly have shared many years as siblings. How many has it been? Over 10?
Few. It's been a few.
It's been a few years. But we, actually, Don, tonight maybe we could talk a little bit about one of the subjects we often ruminate here upon, which is healthcare. And your situation in life is you're a solo practitioner, is that right?
That's right.
So maybe we could talk a little bit about that. I mean, really, I think most people, most that watch the show are patients, they tend to be swept up in a healthcare apparatus where there are lots of doctors. They go from doctor to doctor, and it's not so common. They just have one solo doctor. Is that correct?
Well, that's right. That's a common complaint that I have from patients, that the care is sort of fractured, and you have so many specialists and not one doctor that you can identify with that's committed to your care. It used to be the patient would say, I'm so-and-so's doctor.
Yes.
And you just don't hear that much.
So in many ways, your practice pattern goes back to an earlier time, kind of a Marcus Welby kind of type of arrangement.
You're carrying a little far, Joseph.
Well, is that far back? But I mean, more or less, I mean, the idea that there was a doctor that cared about you, that was your doctor,
right.
You could call that doctor at any time. He would be there for you. He'd be looking after you. And now, people are just being moved around. For instance, if the health plan changed, then you'd suddenly get a new doctor. I mean, do you have any comments about that? I mean, is there that musical chairs of patients?
Right. Well, and we still have a strong cadre of primary care doctors, but the practice patterns have changed so much, particularly patients going to the hospital where more commonly they have a hospitalist taking care of their acute problems, and sometimes the communication back and forth between the primary doctor and the hospitalist is not ideal. And then in the office, the private physician's offices, there's frequently physician extenders, and a lot of time that's where people get more of their care, or at least identification with the nurses or physician extenders rather than the physician himself. So that basic commitment back and forth is sort of breaking down, I think, somewhat. The loyalty, commitment, concern, loyalty back and forth between the patient and physician.
That's that doctor-patient relationship. It's sort of the linchpin of, at least traditionally, the American healthcare system.
Yeah.
I think it's
so
weakened some?
Right, and I think it's so important because I think that's somewhat contributed to the increase in cost of medicine. If you're a hospitalist, you're seeing someone new to you, you want to be sure you don't miss things, miss diagnoses. There may be a tendency to order more, whereas when you have a patient that you know and they trust you, you can be a little bit more practical and fall back on your knowledge of the patient to avoid doing things that maybe are a little excessive, and I think it improves the quality of care and helps limit the cost. For instance, patients call the office. I have a great, I'm in solo practice, but I have a wonderful office staff, the best in the state of Georgia.
Let's be sure they hear that.
That's right.
You're out there to watch that and make sure they get a chance to hear that.
My patients would agree with that.
They're nice people that work with you, yes.
Because we're a small office, we know the patients. They can call in, and a lot of times my folks will alert me and say, Miss So-and-so doesn't sound too good.
Yes, yes.
And we try to avoid going to the emergency room.
Yes.
If possible. Of course, we want to use the emergency room if it's necessary.
Yes.
But just have the patient come to the office, or maybe call in treatment that might prevent further decline.
Isn't that a stressful thing on you, Don? I mean, I think one of the things that's happened is we've had sort of a cultural change in healthcare, and I think we could say, at least you and I, we go back to an earlier antediluvian period where it was 100 or 200 hours a week, or how many hours. You really, really worked hard. No vacation, very little time off, not so much time for family issues. You're really there with your patients, and your arrangement you have in many ways demands that earlier kind of rectitude.
Well,
is that fair? And it's difficult to younger people to
well,
do that.
Well, I share call. I have some great colleagues that I share call with. It's very helpful. But you're right. It harkens back to a time when there was I think a little bit deeper commitment to patients. Not that it's not there now.
Yes.
But I think it's a little less common, perhaps.
We could discuss just briefly our departed father.
Right. I have a memory of our father
Yes.
into his 70s.
Yes.
Being called in the middle of the night.
Yes.
A patient may have passed away.
Yes.
He would put on his clothes. He'd go to the hospital and pronounce the patient, which is something you never see anymore.
Yes.
So that was quite a role model for us.
Yeah, I would say that for both of us, plus our absent brother Mixon, who chairs
speak to that too.
Yes,
I'm sure.
Well, so some of the things are we have sort of a different culture about healthcare these days, do we not? I mean, people that participate in it, the idea is they'd like to have a reasonable life with not so much time, I guess, in the trenches. That's the view, and that means the kind of practice you have might be more difficult to have in the future. Is that fair? I mean, not so many people could do what you do.
Well, there are a lot of dedicated people
Yes.
come along that work just as hard or harder. But I think there is more of a trend towards a more reasonable lifestyle. I think it's more fair to your family. I would have to say that it is stressful. And
Sure.
It's a commitment of your family as
Right.
well as
It's a
yourself.
big family sacrifice
That's right.
to do this.
Yeah,
That's correct.
To do it that way. But there are still a lot of folks that do it that way. I don't think it's really a lost thing at all.
Yes,
but it's less common than it used to be, we want to preserve that. The good aspects of it, I think it's something that's going to stick with us.
Well, Don, this is a good chance for you to opine on almost anything you'd like to talk about. So we've had these conversations about some of the good things we see in medicine and some of the bad things. I mean, good things, the extraordinary technology out there. I mean, just look at it as we go through our daily activities. Wow, look at X-rays. Look at the ability. I mean, just name the things that are better.
Well, the application of the computer to medicine has been revolutionary, particularly in radiography, and it's great for data retrieval. I think the weakest part of this, though, is data entry, which falls disproportionately on nurses, therapists, and I think there's a little bit too much of that burden on particularly on nurses. If you go to a floor or the ICU at any one time, about half the nurses are sitting in front of a computer screen, putting information in, and whereas in the past they would be spending more time with the patients. So hopefully that.
So that's one of the things that's out there. The idea that yes, we're sort of on the conversation about computers, but which has all kinds of benefits accrue to that. But it's pretty tough to put all that data in. Is that correct?
I noticed you've had a little trouble with that.
I have. Yes, it's pretty tough for me.
Yeah.
And I mean, in your
it's
field,
it's great for retrieving information.
If you've got it, once you've got it in there.
And you sometimes as a physician you're sort of a detective And the evidence is easier to gather when you can go back and find lab reports from years ago,
Yes.
history and physicals from years ago, retrieve the x-rays,
Yes,
compare them
yes,
with the current
yes,
films.
yes.
It's a tremendous advantage.
Now, some of the things that have happened, it used to be, I guess you could say this, is a long time ago, the doctors were, I guess, in the situation where the patients were their responsibility, and they used the hospital as the place where they would, I guess, put patients, but the primary responsibility remains with the physician. In some ways, that's changed a lot, hasn't it? Hospitals become a lot more powerful, and they're impacting things in a different fashion, as have insurance companies.
Right.
Would you want to talk about that a little bit, the way it used to be?
I'm not a surgeon. I think the insurance companies probably impact surgery more, although it doesn't look like it's such an impact that we're seeing a reduction in surgery.
Yes, there's a lot of surgeries.
Probably a lot of, frankly, a lot of unnecessary surgery.
Well,
I
good.
think it's fair to say we've talked about
Right,
this
sure.
before.
Let's. You want to talk about unnecessary procedures? That might be a thing to speak about. I mean, the indications to do something. I mean, is it,
Right.
do you think sometimes there's too much being done with different?
Well, you probably know the data better than I do.
Yes.
That there is evidence that there are unnecessary procedures and
Yes.
testing. And I think we all encounter that in our daily experiences.
I think what we need about this is, I think many people are motivated to try and put the best possible system there for the American people. And one of the things is data. So we've got to, if you're in a particular age group, you're an older person, you're getting pretty big operation. How does that? What's the risk-benefit ratio for that? I mean, and I think we also have to think about cost issues. You're
Right.
going to do a big procedure on
Right.
an elderly person, and maybe it's not going to be so great for the person
Right.
that has it, and then a huge amount of resources are expended. I mean, it's something to be thinking about.
Well, we know we're in a crisis, and we as a profession, I think, have to be better stewards of
Yes.
of what we do, how we order tests,
Yes.
procedures, surgery. So much of the technology has been towards diagnosis and better visualization, better testing, but
Yes.
the therapies
Right.
inevitably lag behind, and that's a problem. Patients probably expect a lot more than we can sometimes.
The patient expectations, I mean, I think maybe we can discuss this. The start of our careers, I think people accepted the fact that life, in many ways, was a vale of tears. It was going to be a
Right.
tough thing. They had religious faith to get them through it, and if some good could be done, they would accept that. But I think these days the expectations are that there's nothing that's going to interfere with longevity, great health. You're going to live to 105 in perfect health, do whatever you want.
Right.
And that's not obtainable, is it? We just
Right.
can't do that for people.
Right.
For ourselves, we can't do
right.
it.
And that, doctor, the root word doctor means teacher.
Yes.
That's one of the roles that we have to take up, to teach patients.
Yes.
What the facts are, what can be done, what can't be done.
Yes. Yes.
And that takes time. In a sense, talk is cheap. It's cheaper than ordering a lot
Yes,
of tests.
yes.
Sometimes the education of the patient
Yes.
goes a long way towards improving that relationship.
Yes.
And really delivering better care. We're stressed for time, obviously, and
Yes,
sometimes
yes.
that's not possible. But I think that's helpful.
A person that's, I don't know, when you're a senior citizen, lots of medicine. It's quite a task, isn't it, just to keep up with everything. What I'm, I guess, getting at is sometimes there's just so much information, so much health information that even the most diligent person has to repose confidence in their doctor. I mean,
Right.
you just can't know everything about all these complexities, particularly as you have many diseases. Is that
Right.
a fair thing to say?
Well, it must be pretty daunting to try to sort all this out
Yes.
for just about anybody. As we get older, more treatments, more problems,
Yes.
more complications of medications.
Yes.
And so it is difficult. And patients are looking for somebody to kind of coordinate things.
Yes.
I think there needs to be more of an emphasis on primary care, elevating the role of primary care in coordinating that kind
Yes.
of care.
Yes.
I think that's sort of a bottoms-up thing that
Yes.
the medical profession needs to concentrate on.
Do you think we've got the power to do that? I mean, are we just getting pounded around, I mean, as docs by different organizations, the government, the hospital, the insurance companies? I mean, do we have the ability to say this is the structure we think is going to be best? I mean, it doesn't seem like I hear much on those lines. Do you think so? I mean, do you think we get any doctors say, let's try this, let's try that?
Well, most doctors are pretty busy just trying to do
that's the
a
point,
good
isn't
job. And it is difficult to organize and have time to to concentrate on those things. But you're right. There's I think there's a lot of people out there insurance companies,
Yes.
politicians who have their own interests, and it's hard as a physician not necessarily
Yes.
to
Yes.
to
Well, Donnie,
counteract that.
this would be a good time to say something nice about politicians. Do you want to
Well,
say anything?
I'll be
No,
silent on
we'll
that.
just be all right. We'll
Maybe
pick
for another time.
we need them. I guess we'd say we have to have politicians. I guess we
Right,
could say
right.
that. We need them. It's a tough job. Well, as we look at the situation we have now, I mean, the number of doctors that are in solo practice is going down. There are fewer. It's very tough. Some of the things you have to manage your own affairs in the office. You've got to, I guess, have books and light bills and all the ins and outs. It's complicated, isn't it, doing that? And does that make it?
Well,
Is that a tough thing?
you need help. I have people to help. Everybody does. I think that's one of the reasons a lot of younger doctors don't want to do solo. You have to do the business part.
There's a big part of it, and we're not instructed really
That's right.
about
There's
how
no
to do
instruction.
that. No, how do you do
I'm
that?
Probably the world's worst, and
Oh,
you probably know. But that's a hard part of it. That's not maybe not so rewarding.
yes,
Although it is in a sense having the independence to be able to say, well,
yes,
I want to do it my way, like
Yes,
Frank Sinatra or
yes.
whatever. And it has its rewards, but it is hard. Yeah.
yes. Well, now, Don, there are a lot of subjects we could talk about, and I promise not to talk too much about your football career.
No, okay.
But let's see. So you, let me think. You played for the University of Georgia, is that
Well,
right?
no. Not really. I played for Georgia Tech.
Yes.
Yeah.
Football.
And you were a Harvard star.
Well, that's
you were Mr.
overstated.
Outside, weren't you?
That's an overstatement. But so we wanted to touch on that point. In playing football, I think both of us have done that. That's something that, in a way, sort of prepares you for this type of life. And it's pretty tough, and you've got the sort of. Is that a fair statement? I mean, any things along those lines?
Yeah, I think football is a great game. It's tough. It teaches you discipline, and I would have to say, coming from high school, going to Georgia Tech, with its academic rigors and
Yes.
playing football at the same time was made me grow up a little
Now,
bit.
do you have a lot of PE courses there? Is that what you had a lot of PE?
No, I had a lot of calculus.
A lot of calculus, so that's bad.
And
You had
chemistry.
to take mathematics. Well, now, what about I'll just ask you some general questions. What about the preparation for medicine? So what I was trying to talk about a little bit is things that are sort of character formation issues, maybe, and do we have too much organic chemistry in the pre-med years? I mean, should we do something else? What good does organic chemistry do you think?
Probably not a great deal. I guess it's just a way of establishing some barrier or something that people have to overcome. Show a willingness to work hard, be diligent,
yes.
and an adequate intelligence, which isn't too demanding.
Well, I'll pass on that subject. Yes. So we have the preparation for physicians and how that goes. As you've gone through your career, you've become a pulmonist and lungs.
Right.
Any comments? I mean, the great boogaboo out there has been smoking.
Right.
And so I think when you arrive, the people are smoking more. Any comments about that? Tobacco, good, bad? What does it do exactly?
We're down to about 20% of the adult population smoking. It has come down. The women have lagged behind a bit, and as a result, diseases like lung cancer in women have not come down as they have in men. They've sort of plateaued. But that's a tremendous good if you can accomplish that in any individual patient, help them to get off cigarettes.
Now, I can try to remember some statistics about this. This would be a good time to encourage people to stop smoking. We're on a show here, but how many years before you get restoration of your odds of contracting cancer or chronic lung disease? I mean, any comments about that? You take a decade of not smoking to be back.
It's very individualized. There are genetic factors which play a tremendous role. About 35% or so of chronic smokers will develop COPD, emphysema, chronic bronchitis.
Now, why don't you talk about what that is exactly? I mean, that's a big problem, isn't it? People with chronic lung disease, and what is that?
Well, it's diseases that are primarily affecting the airways, bronchial passages, narrowing, getting inflamed, filled with mucus. Emphysema, the emphysema component is destruction of the lung tissue with dilation and expansion of the little air sacs or alveoli. So it renders the lung much less efficient over time, and generally progresses. Smoking cessation will help slow down the progression, but if you've smoked for a long enough period of time, the disease tends to progress not quite as rapidly if you quit smoking, but it still progresses.
So when people start smoking, many people they think, well, I'll get lung cancer, but the worst thing, I mean, as far as the bigger the chance is to get chronic lung disease, which is
lung cancer is close behind. It's lifetime smokers. It's about 1 in 10. It's like a Russian roulette with a
1 in 10 for lung cancer. That's 40-pack years or something. Big.
Right, and there's some data that there's a critical period as a younger person and you smoke that may influence not just the pack years, but when you start smoking, that puts you at greater risk for lung cancer.
And so that's one of you really encourage your patients to stop smoking, and are you successful sometimes?
Well, I remember our dad was known to snatch the cigarettes out of the out of the
so
patient's pocket.
So he was a pretty tough guy.
That was pretty dramatic.
He didn't like the.
Couldn't get away with that these days, but yeah, it's we spend some time on. Every patient comes through the office, we make notation of smoker, non-smoker. If you're a smoker, we pay particular attention to that and work on that.
Yes. Well, now, I think the patient population, you're seeing an older group of patients, are you not? I mean, so the life expectancy is getting more pronounced. And is that an issue that you often deal with, an elderly patient that has lots of different diseases, different kinds of medicine, the lungs a big part of it, and how to make the right decision?
Well, sure. I think pulmonology is sort of unique in that we have an office practice. You see young asthmatics, you have people moderately sick in the hospital, you have ICU patients, you have those few surgery patients who have complications that we have to see from time to time. And then you also have patients who are chronically ill, ventilator dependent. We now have special places for them called LTACs, long-term acute care facilities. So you sort of see the whole gamut. And you see how people do at the end of life, and you try to contribute to that care. And with my patients, I try to steer them away from going that route where there doesn't appear to be much chance of recovery. To avoid that, and So that's a big part of what we do. Yeah.
Yes. Now, these LTACs, what exactly is an LTAC? Maybe you could speak some more about that.
Well, long-term acute care, they're facilities where patients with more chronic problems who still need some of the care that would be typical in a hospital setting are provided that. And a certain percentage of those are patients who are on the ventilator or ventilator dependent, not able to be withdrawn from the ventilator.
Yes.
And some of them do eventually come off and some don't. There are other types of patients who require long-term IV antibiotics for a variety of reasons,
Yes.
unable to go home, but they don't,
Yes.
they're not quite ready for nursing home
Yes.
or for rehab facilities.
So one of the things going on is we face different kinds of problems. I guess the system is putting in place institutions or facilities to take care of a particular need. And is there a local such facility
That's
here?
right.
in
Regency
Regency is a
Hospital
local
here.
facility, and
Right.
they take care of those patients.
Right. There's also a nursing home, Heritage
Yes.
Nursing
Right.
Home. I don't know
Yes.
if you're familiar with that or not, but it's a nursing home that has ventilator capacity, and I don't know exactly how many
Yes,
patients
yes.
there, but a goodly number.
Now, occasionally people need lung transplants, which is a rather
Right.
exotic thing. When would a person need a lung transplant, and does that ever happen, and is that complicated? And
Well, you take a guess how many lung transplants in this country every year? Take a stab.
200,
A bit more than that.
20,000.
A bit less. Only about 12 to 1,500 a year.
Not too many.
Not a great number.
It's a small number.
Right, relative to the number of patients who are dying with lung disease. So it is done. We refer patients usually to the Emory transplant
Yes.
service, and these are patients who obviously have chronic lung disease, but are considered viable. They have to have a lot going for them with their families to provide support and psychologically be able to contend with a lot of the challenges that go with being a transplant patient.
Yes.
So it occurs. I've had several over the years that have had lung transplants.
Yes.
The outcomes are not quite as good as with, say, kidneys or heart because of some increased immediate mortality and then rejection.
Yes.
So the overall 5-year survival is 40 to 50%.
Yes.
So you want to be at the latter stages of your disease process before considering that.
Yes.
But it's something we talk about with patients, and we've had some successes.
Well, good. Okay. Well, Don, on that note, I think we've run around the track a little bit. Well, it's been great. It's been great having you here.
Well, it's great to be here. You have a bully pulpit here, Joseph.
Yes. Well, thank you. And Don, we'll have to have you back, and just keep up the good work.
Okay.
And I'm proud to have you as my brother.
Bro.
Thanks a lot.
Good to see you.
Thank you.
Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.